took out the audio, so it's good. Good evening, everyone. We are today giving another webinar regarding active surveillance in our series of active surveillance. This time we have the opportunity to have this webinar done by Tania Estapé, which is a part of our board member of Europa Uomo, and she is say the contact in the Spanish division of local association. Why we choose this way? Because Tania is a psycho-oncologist, and so she can give an overview, some indication about her experience in this area of active surveillance with patients. So there is no particular things to discuss further, and I will leave the words to Tania. So Tania, you can go on.
Okay. Can you see my screen?
Yes.
Now. Okay, I am going to talk about anxiety and depression in general in prostate cancer patients, and finally some tips related to active surveillance. Thank you, Cosimo, and thank you, Anya, Ioannis, Europa Uomo, to allow me to present this webinar. I am here talking on behalf of Europa Uomo, and as Cosimo stated, I am in Europa Uomo on behalf of my organization in Barcelona, set up in 1996 with the main purposes to provide support, information, training to patients, but also to relatives. And also we do a lot of public awareness programs, because we strongly believe that cancer is so high in frequency nowadays that we should promote awareness in population, in people, in public, people that perhaps in the future or now are having cancer or will have cancer or have a relative with cancer, because I think when cancer is a matter of all, and we should have awareness to go early to detection or change our lifestyles and so on. From the very beginning, we have this website, which especially after COVID has been very useful to contact patients and allow us to do work parallel to our face-to-face work. This is our main web. And we have 4 websites, one especially devoted to prostate cancer. We have a group, a super group from 2000, and a lot of information, newsletter on this cancer. At the beginning, when we began, we see the breast cancer website and prostate cancer website very similar, only different in color. We have few consultations from prostate cancer web, but nowadays is the first one. We have a lot of activity in this web. So things are changing, but we need they change a bit more to allow men to share their emotions, their fears, and so on. This is our website of prostate cancer, which is in Spanish, but also available in English, that nowadays, as I said before, is one of the most visited in our organization. As I said before, I am here on behalf of Europa Uomo, which is the European organization that includes all the associations, the local associations in Europe, and is doing a lot of work, especially to promote quality of life of prostate cancer patients and their relatives, to promote prostate cancer screening programs, because we know as earlier as prostate cancer is detected, the consequences are less harmful for patients and for family. and to promote better treatment and awareness towards this cancer. Europa Uomo did a study, perhaps you have listened about it, have read, is Europroms. Just I include a slide of this interesting study, and you can see that more or less half of the patients interviewed, more or less 3,000, are recognized. They are extremely, slightly, but in some way, anxious or depressed in some extent. So also, if we see what happens in psycho-oncology field, my own field, I am clinical psychologist working with cancer patients from the beginning of my professional journey. We can see that prostate cancer, being a cancer that harm quality of life, as I will develop in this webinar, is not represented as others, for instance, breast, in psycho-oncology field. In the recent Congress of Psycho-oncology, where I present Europrom's study, there were only 7 abstracts related to prostate cancer versus 50 related to breast. And in our journal of Psycho-oncology, that is working from more or less 5 years ago, only 9% of the publications are related to prostate cancer, compared with 29, for instance, with breast, or 17 gynecological. So from the psychological point of view, it has been a silent cancer. It's rising up, mainly because of the age of patients, but also more awareness. We have more and more patients, and we have a specific men coping profile that must be taken care when we talk with cancer patients. I always say to Europa Uomo board, I admire them, I admire people who is giving visibility, but we know there are silent people who don't dare to explain they have cancer, prostate cancer. They are living it with shame, feeling they are less men, and so on. And we need to also reach these men that need us. Let me begin from one of the parts that makes psycho-oncology necessary, and this is related to sociocultural attitudes toward cancer. We can see, for instance, in Europa Uomo, differences from people who is from Mediterranean countries, people who are from northern countries. So, and if we see the globe, we will see in some countries from Africa, for instance, the word cancer doesn't exist because it's a sentence, that sentence. So cancer as a word doesn't exist. So it's very important to take into account sociocultural issues, because we as individuals act in part as our culture, the schemes of towards cancer of our societies are inside us. Sometimes we are not aware of that, but we have these schemes in our brain, in our thinking, in our feelings. Cancer is a taboo disease because it's relation to death, suffering, to pain, and also because it has consequences in quality of life. Why I am putting here the tobacco? Because we know that tobacco is one of the known causes of a lot of cancers. But we know that some people who have smoked a lot in her life has no cancer, no lung cancer, for instance. So the population, people we are talking in our talk, in our speeches, say, oh, it's not true. Smoking can yield cancer, because my sister or my brother or myself have never smoked and I have lung cancer. So the cancer causation is one of the things that led to taboo. We don't know, we know some causes of cancer, some factors that can lead to higher risk of cancer, but we don't know exactly the causes of cancer. One of the beliefs of some societies, and even in the current time, in some groups of the population, is believed that cancer is a contagious disease. Not exactly contagious as you touch a person who have cancer and you have cancer, but sometimes people who have, especially cancers that are in the face of the person, that people don't want to touch them or kiss them, or are not very prone to be near of people who have cancer. This is image I take from this web that is very interesting. I had cancer, where they say I had cancer, not cooties. You cannot have cancer touching me, kissing me, and so on. That's how some cancer patients feel, that if they say they have cancer, people is not so prone to kiss them or touch them. In our study related to attitudes towards cancer that we published in 2020 with 814 people from 60 years onwards, we found in Spain that 2% still believe that cancer is contagious and 12% are not sure about that. That is few people, but we were worried about some old people or some people, because we do also this work with women that have no health literacy, and there were similar percentage that feel that cancer is a contagious disease or cancer is a punishment consequence. We include in our questionnaire a question said cancer appears for something bad you have done in the past, and 5% say yes, and 11% say I am not sure. And I am a clinical psychologist, and every day I see patients that say I don't deserve this, this is a punishment, I have been right all my life, I have been good, why I have this illness. Other misbeliefs we have found in public education programs is thinking that if you are positive, you will cure of your cancer. The first thing, you should go to early detection, and the second thing is have treatment as soon as possible. If you are positive, you will be better, your partner will be better, your family, your friends, but it unfortunately don't rise your chances of overcome cancer. It's not shown by research. Only we have indirect influence. For instance, people who are positive are changing their lifestyles, are going to doctor when it's programmed, and see that 69% of 2080 prostate cancer we interviewed say they have felt this pressure to be positive, and they felt bad because it's not exactly how they are feeling. We should allow people feel their own emotions, and when there is a diagnosis of cancer, there are no positive emotions, at least as the beginning. Also, we still have people, and at least in my country, rising people who, instead of going to a doctor, prefer to take miraculous cures, or for instance, shark cartilage tablets. We have found it in 27% of our prostate cancer patients. This is a topic of another webinar because we have a lot of figures about that, but we are seeing people that are going to other cures because they feel perhaps they have a diagnosis, a fatal diagnosis, and they go to other cures that usually are harming the patient and the families. The last thing related to the taboo part, to the sociocultural part, is we still use cancer as an adjective. I have found here, because I have my slides in Spanish, but I see also in the UK, in the USA, the use of cancer. Look at the Thesauros, this dictionary, where apart from pathology, cancer is defined as an evil condition or thing that spreads destructively. Our politicians are using cancer to destroy their adversaries. Our journalists, this is a word that is used to harm the adversary. So it is prolonging the belief that cancer is awful. If you have cancer, you will die anyway. It's an awful thing that spreads, so it's a punishment, and so on. Susan Sontag, that was a sociologist that wrote a very interesting book, called Illness as a Metaphor, say to describe a phenomenon as a cancer is an incitement to a violence. The use of cancer in political discourse encourages fatalism and justifies severe measures. So we should say, and it's an awareness work we are doing from some years ago to politicians, journalists, and famous people not to use cancer to say something is very bad or something is awful. Going to the part of quality of life, we must say that diagnosis of cancer is an impact that sometimes breaks the meaning of life of the person who received it. People gives a meaning to cancer, usually the meaning depending on their life, the moment of the life cancer appears, that yields to uncertainty. That is what is more difficult to cope with, for patients said. I felt secure, safe in my life until now, but now I don't know what will happen tomorrow, if cancer came back, blah, blah. It's a change in their life. They feel their loss of control. A patient the other day told me, another person is driving my car, doctors, nurses, psychologists, not me. So I feel I don't know how I am going in the car, because the car is my life. But I don't know where the car will go, the next step, the next stop. And it yields a change in perceptions towards goal, future, and self. After cancer, mainly people say my life is not the same. I feel life differently. I feel my relationships differently. So there is a philosophical consequence. Related to quality of life, we have different areas: general well-being, how are you, how do you feel, psychosocial aspects, mainly anxiety and depression, that I will go more deeply to these aspects. Work-related problems. In the past, all cancer patients died, so we didn't have work-related problems, but now we are having people who were working when they were diagnosed and they have problems. We have working hard on this in my organization, because we have is a problem, even a psychological problem, because some people who were working want to work again, and they have several barriers from their organizations. It can impair cognitive function, loss of memory, attention, and some others that contribute to low self-esteem of patients, and physiologic conditions like insomnia, pain, and sexual function. All of these aspects are related. Of course, if you are depressed, you cannot sleep well. So it's areas, but all of them are related and depend strongly of clinical course and patient characteristics. When we talk of cancer, we talk of 200 different conditions. So we cannot say cancer as a box. We have prostate, breast, and even inside every tumor, we have different situations. In our data, we know that 53% of patients have problems, but that normal reactions to cancer: stress, day-to-day difficulties, loss of autonomy, but psychological problems that are, we can say, normal. usual, that are not, you are not a psychiatrist patient. You are a patient that have been diagnosed with cancer, so you feel bad. As I said before, it depends strongly on where you are from, cultural issues, not only because of misbeliefs, also, but sadly, economical resources. We know that some cancers are cured in some countries and are fatal in other countries because they have no way to cope with this, because they have no, for instance, in Africa, in some countries, people are walking 3 days to go to receive radiotherapy. 3 days back, I go, 3 days back. So it's difficult to imagine that they have a positive attitude when they have cancer. Also, it depends on the family matters, the stress the patient have when reach cancer diagnosis, the life cycle, young, old, older, if he's or she's working, and so on. Patients arrive to cancer diagnosis with their own back, their personality traits, their past history of different illnesses, and one is, of course, tumor site, and we have here Mr. Prostate as a characteristic that will yield different attitudes to other tumor sites. First of all, gender differences. We know that men are more reluctant to go and seek for information related to health, especially when they are healthy, when they have no illness. When they are diagnosed of an illness, they are more active. But we have done a lot of public education programs to breast and prostate. And when it's breast, we have 1,000 women. And when it's prostate, we have 2,000 women and 100 men. So men are more reluctant also to have information on preventive and early detection behavior, and related to psychological issues, more difficult in expressing emotions, shame about some medical tests that women are more used to. And see this graph of our organization with cancer patients, breast, prostate, colon, all tumor sites. And we always see that men are far less depressed and anxious than women with cancer. I must say, I have my own interpretation of these results, because sometimes I have patients, prostate cancer patients, for instance, who is crying during the clinical interaction, and then answer the questionnaire saying 0. I have no fear, I am not crying. So we have, at least in my country, still the male prone to proneness to be, I must be hard, I cannot express fear, I cannot cry, and so on. Things are changing, but still like now. Go and see what happened with depression. First of all, depression is cumulative. After fighting with illness, coping, having different situations, treatment, recurrence. Some people is depressed because it's in some way give up the fighting. No, depression is a condition which the emotion is sadness. Sadness is not a problem. The problem is that sadness can become depression. And sometimes it's difficult to be aware of when sadness is going to depression. And even in depression, we have a wide variability according to intensity. We have people that is highly depressed, major depression, or people who is depressed, but not so in a serious way. But it's important to admit that sadness is a part of our life. Emotions are here because we are alive. When we have no emotions, we will be dead. We have emotions that have a function to help us to cope, to say something to us, to say something to others. If we are doing a sadness phase, my partner, my sons, or my father can see what happens to you. So it has a function. We cannot reject these normal emotions. Why we have depression in prostate cancer patients? I must say all cancer patients usually is high, anxiety is higher, except in prostate cancer patients in whom depression is higher than anxiety. For instance, we can talk about empty nest. That is a thing always, at least in my country, related to women when sons and daughters are get older and they go to their own houses and marry and so on. But we can see also in these men, they sometimes are retired. And we know, at least in my country, that some men or most men have built their own identity related to work related area. So when I don't work, I am useless. What my life is empty. And if we add side effects of prostate cancer, especially when prostatectomy is required, loss of erection, loss of urinary continence, sometimes we have a perfect situation to provoke depression. Also, as I said before, the self-identity. As I said before, all people, at least in my country, and especially men, are very related to their work life. In our group, some people introduce themselves saying, I was the chief of commercial strategy in a very important organization. I was a professor of the university. Instead of presenting, I am John Smith. I like to go to walk. So it's very important to take this into account, because when you have problems with your identity and you lose things that are building the identity, it's easy to become depressed. Also, social relationships impairment. Cancer may yield to sometimes isolation, and in prostate cancer patients, we see some shame. It's strongly related to side effects of treatment. 58% of our patients have urinary incontinence, and they say, "Oh, I don't want to go to this conference with my friends because I don't know if there will be a toilet." Or some people who don't want to go using the car because if they are in a rush, they perhaps I don't know where to go to the toilet. Also, related to that, they feel insecure in some activities. In our data, 39% have experience limited in their life. They are not going to see their friends, they reduce their social activities. And this is, in my country, 43% haven't explained to friends and even to some relatives they have prostate cancer diagnosis. Be aware, especially related to depression, of past history. Men who before prostate cancer suffered from depression or another psychopathology problem are more at risk at being depressed when they have prostate cancer, because they are people more vulnerable to life events. If depression is too long in cancer journey, it's maintained even when no evidence of illness, we have a cured prostate cancer patient, but after 2 years, 3 years, 4 years is depressed, we must be aware, because in depression, the problem, as I said before, is to go from the mild depression to serious depression. And we must be aware of the signals. Which signals are that? If we've found the following points in a too high level. Stop leisure activities. I don't want to go to the cinema, to enjoy some time with my friends, take a beer every day, don't want to do this, don't want to do that. Feelings of being uselessness or being a burden for relatives. Some people are saying, I am causing harm in my family. In some way, they identify themselves with the cancer. You are not your cancer. You are a man who has cancer. That is very different. Activities are seen as climbing high mountains. They say, every day when I wake up, I see, oh, this is another day. We will be awful. I want to go to sleep again. Saying you want to go to sleep is a way of saying you want to not be conscious of your life. So please be aware of this kind of sentences. Prefer to be isolated, even being all the day in the room, in the bed, not waking up, not taking a shower, not put clothes all the days in pajamas. And also sleeping disorders. In depression, it's usual that they have difficulties in falling asleep. There can be 1 hour, 2 hours, 3 hours before falling asleep. And this is the other extreme of depression. I have told on sadness, some mild depressions, major depressions, and in another extreme, we can have a very sad thing, because in the first year after diagnosis, prostate cancer patients are the ones that more commit suicide. So please be careful, because a serious depression has a death risk, which is suicide. It's not very frequent, but it's a risk. When the patient begin to express death-related thoughts, you will be better without me, I would like to sleep all the day, I wish tomorrow I won't wake up. This is some tips that we must be aware of. Let's go to anxiety. Anxiety is a clinical version of fear. Again, as I said, related to sadness, fear is not bad. If human beings have not fear, we won't be here, because you need fear to cope with a danger, to see when a thing is a danger, to run away from a danger or cope with this. So danger, I fear, is normal. It's normal. Please do not make patients feel bad because they are sad or fear, if it's normal. If they have again a past history of anxiety disorder, they are more at risk. But again, fear is a necessary emotion. When it's a thing of alarm that we can say it's not normal, when it's too high. Not coherent, I mean coherent, people who is well, all the tests are fine, you are cured from 1 year ago, and you still feel anxious. We must take it into account. Too prolonged over time. Usually it appears in peaks, not as accumulative as depression. Peaks is before test, before treatment, the first days you will receive chemotherapy, before the prostatectomy. This is normal. You have fear. But if after this it doesn't disappear, perhaps we may be aware of that. And especially when it interferes with decisions. Decisions you must take, decisions among treatments, decisions with your family, with your future. Anxiety is blocking you, then it's a problem. Which are the causes of anxiety in prostate cancer patients? The most known is the PSA anxiety. There is some studies that say the PSA stands for promote stress and anxiety. That wants to say even there are some studies that have found a clinical course of anxiety related to the days patients must go to do the test. So PSA is for some patients an obsession, the point for the point two, the point, and they are so controlling this that is very anxious for them. This is one patient of our super group to show how they do these graphs. We never see this in breast cancer patients. And another source of anxiety is the Damocles sword syndrome, fear of cancer recurrence. All the people know that cancer is a disease that can reappear, can recur, and there are people that are extremely anxious about that. That every day when they take a shower, they touch their body, or there is a lump, or I feel some bleeding that is not real, but I am going to the toilet every 5 minutes. And when appears the fear of recurrence? When you have controls, the visits to control how is the situation. When you see in the TV some, I don't know, actor have cancer, when you feel some pain that perhaps is, I don't know, arthrosis, or you have a non-important pain. But it's very curious to know that some people have fear of recurrence in happy moments. It seems people, when we have talked about in my team, people who have got cancer, when you ask them, how are you? Never say fine, well, very well. Say, well, by the moment, well, we are more or less. So they are sometimes have some fear to be happy, to say, oh, we are happy, I am cured, prostate cancer is overcome, and be careful, perhaps it comes again. So there are in some way fear of being happy or live life with joy and as before cancer. Another source of anxiety, of course, are treatments. All cancer treatments can yield anxiety before surgery. Chemotherapy is the most feared treatment in all cancer patients. It's not so usual in prostate cancer patients, but some of them receive chemotherapy, and we know what is chemotherapy, and people are anxious, oh, I don't know if I will be able to receive it, if I cry, or what will happen. Radiotherapy, that is not so feared as chemotherapy, but it's a treatment, so people have some consequences. And hormonotherapy, we know hormonotherapy can help emotional ups and downs. Prostate cancer patients that I see in the hospital sometimes are people who is under hormonal therapy. I am crying, I am angry, that is emotional loops. And especially the medical decision-making. One thing that provokes anxiety sometimes is having different doctors in the scenario. If we see this tale, I don't know if you know, the 4 blind Indians with an elephant. The one who was touching the trunk said, this is a snake. The one who tied the ear said, this is fun. The one to take the body says, this is a carpet. The one that ties the leg says, this is a tree. So one patient of mine said, but I am the elephant. And the radiotherapy, say, do radiotherapy, urologist, please go to prostatectomy. And some patients are a bit anxious because they don't know, especially if doctors are saying different things. if you do radiotherapy, then we cannot do the surgery. Radiotherapy said this is not true, and this is a thing that provokes high peaks of anxiety. The fear of cancer recurrence, we must say, and especially in active surveillance, these two options that both can yield anxiety. One is what I said before, the sword that is here, that can fall in my head in every moment. But people under active surveillance that are with the tumor inside, as one patient told me, I every day wake up knowing I have cancer inside me. This is a shadow. This is not a sword that can fall. This is my shadow that is always with me, in my feet, always when I am walking, when the shadow is here. So let me talk about active surveillance. That is a very good news that people can avoid sexual problems, urinary problems, and so on. But still there is patients. I know in some countries there is high figures, but in some countries it's very difficult. People feel they are not doing anything towards cancer. We have learned when you have cancer, you should treat and remove as soon as possible. And the doctors are saying, no, you should not remove. Some doctors are not very prone of this. I know some urologists that are not very prone of this option. So if patient sees doctor is not very convinced, they won't choose this option. Family pressure. I have now a patient whose partner is very angry. He says, how can you say to my husband not to treat? This is cancer. We want to be together as much as time possible. He will die. Also, the self-pressure, the pressure that patient do to himself, feeling I am doing nothing. I am not controlling. I am not coping against cancer. The anxiety source in active surveillance option, difficulties in medical decision-making due to age. If we are talking about old people, people are still more from the time that cancer must be removed. What we are doing, cancer is here every day, we should remove it. Difficulties in all people, or in not also all, but in some people, in taking an active role. We have patients that say, I don't want to decide. We are coping for the patient making decision, but some patients feel not comfortable. They don't know. I don't want to take this decision. I want to do what doctors say. So more anxiety, more difficulties. They are anxious every day. They have the tumor inside and have more difficulties. In some studies, even more difficulties that some patients that have undergone prostatectomy, because they feel every day, oh, I have cancer, perhaps it is spreading, I am not doing the good option, and in some cases, depression because they feel isolated. They feel isolated, perhaps, for instance, if they go to group, we have group, and nowadays, active surveillance is not so usual in my country, and they came and I have been under surgery, radiotherapy. Oh, all the people have received treatment. Perhaps my illness is more serious, and my doctor don't want to tell me the truth because they haven't treated me. Before ending, in every situation, I have mentioned family. Family is important, is one option that can help patients in making decisions, in decide active surveillance and give support. In Psycho-oncology, we say family is the second order patient because they have the same problems, psychological problems, but not the physical illness. In our patients, only 8.3% have experienced family problems, especially in couple relationship. We must say in our experience and until now, prostate cancer patients are strongly supported by their partners. But sometimes what happens is another elephant, a white, big elephant in the room. There is an elephant in the room, and every day we wake up, my partner and me, good morning, we see the elephant, we do our life. At night we go to sleep, the elephant is here, but we never talk about this. This is the problems in communication, the elephant. So, I am fear, you have done active surveillance, perhaps it will appear again. Please don't, cancer is, of course, a negative life event, but sometimes, as I said before, people arrive with a back to cancer diagnosis. We have seen that related to sexual issues that we will talk in another webinar, 43% of our patients reach with previous problems, and in Europe's study we have found the same. So it's not cancer, it's not prostate, it's not prostatectomy. Sometimes patients arrive to diagnosis with some problem issues. The problem is some of them keep drive. But see this book, very interesting book from Barbara and Ralph Alterowitz, that they have reported a patient that after 11 years of prostate cancer patients and no relationship, not sexual relationship at all, the couple have never talked about that. So the big white elephant in the room. I must say that sometimes women, I know that some prostate cancer patients have a man partner, but I am talking of we see more frequently, at least by now, one that the man talk, express the emotions, talk about emotions, and sometimes men is not so prone. We don't need to make that the man now is very talkative and change because he has cancer. He's the same as before. So it's important to respect his way of being, his personality, because if he always has been a person not very talkative, closed, he won't change because he has cancer. Sometimes the contrary. To finish about depression, tips to be aware. Be aware of anxiety, the past history, as I said before, too long, as in depression, even when no triggers are present, no reasons to be anxious. You are anxious, we have a problem, and when symptoms of anxiety are too high, feeling nervous, restless, or tense, having a sense of impending danger, panic, doom, having an increased heart rate, breathing rapidly, people have some problems in their ventilation, sweating, trembling, feeling weak or tired, poor concentration, or thinking about they are always obsessed with their situation, and this is related to cognitive anxiety, the anxiety that you are in your brain. Also sleeping difficulties, but differently than in depression, because perhaps they have no problem in falling asleep, but after falling asleep, after 1 hour, half an hour, they are awakening and with high anxiety. I know some patients are awake during the night because they go to the toilet, I know, but this is different. They feel they are with bad dreams, they feel bad, they are sweating. This is anxiety. And as I said before, when is danger, the anxiety? When it interferes with our ability to make decisions, even life-threatening ones. Some patients are avoiding going to test. After 1 year, they are so afraid that illness is coming again, and in some way, they are threatening their own life. Some tips. It's important to maintain a structured day. Some people, because they are retired of work or they are depressed, they sleep until 11 a.m. or then go to sleep very late. It's good to rest because you are retired and you are ill, of course, but as much as possible, it's important to maintain a day that you work during the day and sleep during the night. It seems simple, but it happens to some patients that they, oh, I am not, nobody needs me, I don't work, so I am sleeping, or then at night I don't want to go to sleep. And it's very related to depression, this losing this structure. As much as possible, keep activities even when you are not motivated. It's a very, very frequent reason to consult psychologists. I do the things. I go to the cinema. I'm going to with my wife to take a walk. I go, but I want to be motivated. Emotions are going two directions. When you are, the emotion is needed to be motivated and do the behavior, but doing the behavior, your emotions will be better. Sometimes you should do a smile to feel better, not wait to feel better to smile. Look in your past for things that make you happy and take them to the present and do things that are small. Ordering your drawers, your books, your pictures, do manual things that require your attention, and then your brain is not thinking in other things. Surround yourself with people who make you feel good, but be kind to reject meeting those who don't. Cancer is a long journey. Perhaps at the beginning you don't want to talk with people, or yes, you want to explain to all the people. It's like the music, that some music is good for you, some music, you don't like this music. So please share your time with people that feel you good, that only you know who are them. But don't feel pressure to go be happy. I must show my best facade. It's not like this. Emotions are part of life. So in the first year, it's possible you have different moments of ups and downs. Honestly, communicate with your partner. If you have no partner, other loved ones. Cancer won't change you, as I said before. So feel free to explain or not. There is a pressure that you must explain, because if you don't explain, something wrong happens to you. I can say that I have patients that haven't explained only to their family. They are happy. They are very adapted to their cancer situation, but they don't want to explain to all the people, as it seems nowadays we must do. Even in Facebook, in Twitter, in Instagram, people doing pictures with no hair, pictures, and it's not compulsory. Use breathing and relaxation techniques. Some professional can show you, because some people is not aware they are not breathing in a good way. Physical activity is shown to reduce moderate depressions. If you walk, for instance, every day at least 30 minutes, is shown that depression is less serious. It's not a treatment for a serious depression, but it's demonstrated with researches that it can improve your mood. And please do not hesitate to seek for professional support. You are not crazy if you need a psychologist. You are a person who is trying to cope with a cancer diagnosis. As I said before, your fear, not necessarily anxiety, your sadness, not necessarily depression, your emotions are here and can lead you to a behavior that is not good, to be bad with your partner, to avoid seeing people. So even when it's not depression or anxiety, even when your emotions are interfering in your daily life, please seek help with a professional. And perhaps he or she will say, you are fine, it's normal. Okay, but why don't go to a professional, to a mental health professional, as you go to a doctor when you have a tumor or a physical problem? This is a barrier and a stigma, especially in men. Or seek for a support group, taking into account that, again, it's not compulsory. If you don't want to hear other people, their problems, you will feel bad, or you can try and then don't go anymore because it's the music. You can see if you are fine or no with the group. As a conclusions, I am optimistic. The slow increase in participation. One example is Europa Uomo. People is sharing their emotions, their worries related to prostate cancer. We have a prostate cancer profile, especially related to being men. We must take into account what is anxiety, what is depression, when people is at risk of having serious problems. And usually in group, sexual dysfunction is the main problem, with a high percentage of maintaining sexual desire. What yells, depression, because they feel they are not male. They are, in Spain, is especially present this concept: I am not a man, I have no erection, I don't work, my son doesn't need me anymore. So we must promote to take into account these problems. And that's all. Thanks so much. This is my email, just in case somebody want to comment or ask me.
Thank you very much, Tania. We really have seen a lot of information from you, and that was very complete overview. Certainly, it could be, I don't know if someone has some question, even if we are around the end of the slot we put. In any case, I wanted to say that this idea of putting evidence in the psychological aspect will be is important, and so Tania has already in mind. I hope she will be able to do a further webinar on the couple life, on how to cope with what is normally happening in our life. So people, we are not living alone; we're living in a family. If there are questions, we can go on, or we can.
No, just before we close down, Cosimo, first of all, thank you, Tania, for the excellent presentation. When you were presenting it, I'm sure that a lot of us, we have seen our life through this book.
Yes.
So very much appreciate. And I would like to underline one very important thing, is that awareness is the very first step for everything in our case. In prostate cancer, we have to do whatever is possible to be done to increase awareness. That's why this morning, the whole 27 organizations, you have received an email where we said to the certain countries that they have projects, but they don't have capabilities, that Europa Uomo would like to help and support. And the second thing I would like to add, Tania, after your excellent presentation, is that very soon the partner survey is coming into reality. So I can see the smile from our dearest Harry and Irma. I know Irma how much she has been supporting this project. So I would like all of us within our organizations, within our countries, to make sure that we have enough answers from the wives, from the spouses, from the caregivers, just to see what is the difference between what I have indicated in my quality of life and what my wife, she will indicate in her report. So thank you very much from my side to everybody. Let's increase awareness. Let's make sure that everybody knows a little bit more about prostate cancer. And I look forward to our next webinar, dear Cosimo and dear Tania.
Thank you.
Thank you.
Thank you.
Thank you, Tania. It was very interesting.
Thank you.
Thank you very much.